Now I'm going to move on to new research in PSC. I'm focusing predominantly on the therapies that are in research, and I'll just brush on some other types of research, and I'll also mention my research that I'm doing in my PhD. So currently, the treatment options really are ursodeoxycholic acid, which I imagine many of you are on. This is not a uniform treatment around the world. I know in Canada, Bertus Eckstein's group, who Dr. Chapman alluded to, most patients are not on ursodeoxycholic acid. Most European centres have patients on urso, and most English centres. Australia, there's no one on ursodeoxycholic acid because we're not allowed to give it, and we'll get struck off because we'll be audited because it's not listed it's not licensed for that. So they're very strict in Australia, and you wouldn't get it there. We know that ursodeoxycholic acid reduces your ALP, your alkaline phosphatase, the liver test that's up in PSC. And that was found in 11 out of 12 studies over the last 20, 30 years. Some of the studies show that it improves the changes on your liver biopsy. And there are some studies, although there's some conflicting studies which are against this, but there are some studies that it also does reduce your risk of developing bowel cancer. However, there hasn't really been any conclusive evidence that it slows the progression of disease and prevents liver transplant. And I'll talk about some of the problems with trying to reach this finding in making up clinical trials shortly. We do think that it is an immune-mediated mechanism developing PSC, and there are small studies of various drugs which you may have heard of and may have had with your inflammatory bowel disease, but they've all been mostly less than 20 to 30 patients, and no clear benefit has been found of these drugs. A lot of patients with PSC are on 5-aminosalicylic acids, so they're like a topical form of aspirin, Pentasa, Azicol, Salifolk, and these are treatments for colitis, mainly for ulcerative colitis, occasionally for chronic Crohn's disease. And looking at whether they actually are performing an added benefit, potentially they have a role in also reducing colorectal cancer, and we do advocate patients being on these for control of the colitis and for potentially having a protective role for colorectal cancer. So the challenges in designing and carrying out trials in PSC, one of them is pretty obvious, that PSC is such a rare disease, and so it's difficult to get enough patients in clinical trials because you need to have a core amount of patients to be able to detect a difference in a trial therapy versus a placebo. And one way that we're getting around this is joining forces internationally with other centres. So you might have 4 patients from Oxford, 5 from Birmingham, 10 from Germany, 5 from Norway, etc. And when you add them all together, you can get numbers of 200 to 300, but it's a huge effort. Another problem is that the time it takes to get to a clinically meaningful endpoint, such as needing a liver transplant, is 10 to 20 years, which is far longer than any clinical trial run that I know, and far longer than the money that the drug companies have and that they're willing to invest. So there's a very big focus on surrogate markers, so other ways to predict whether you are going to have a worse outcome or a better outcome. So predictors of needing a liver transplant, predictors of developing cancer. And that is something that Dr. Chapman's involved with and was at a meeting in America recently, and which is being published a lot in the literature. But it's a matter of the drug companies and the licensing bodies all agreeing what those surrogate markers are. The other problem with designing these trials is that PSC is a heterogeneous disease, which Dr. Chapman alluded to. And this is a diagram that he has come up with showing the 3 different types of PSC. So some patients do very well, and some patients have complications, but there's a wide variety of different complications. Patients may or may not have inflammatory bowel disease, and there are different types of bile duct strictures. There's ones within the liver, intrahepatic, ones outside, extrahepatic. There's dominant strictures or not having dominant strictures. So it's very difficult to just have the same PSC patient, and potentially different treatments work for different types of PSC patients. Now, I don't expect you to take in everything on this slide, and there is quite a bit of medical jargon, but just to say that there are lots of different steps that we think in the cause or pathophysiology of PSC. So there's genetic factors, There's two types of immune roles. The innate immune role is the first line of defense role, for instance, the first attack of bacteria. And adaptive immunity is the more organized, sophisticated form of immune system. And we think that both of these parts of the immune system play a part in the cause of PSC. There's roles of biliary fibrosis, there's an area of scar formation in the disease. So we think there's this initial inflammation that then leads to scar formation, and potentially patients with PSC have a predilection for forming scar tissue, but this is another area that we can target with treatments. And then there's a theory about patients with PSC having a more toxic form of bile, that the bile is attacking the bile ducts, and so we can maybe target this area for treatments. Safe to say that this diagram shows you that there's many aspects of the pathophysiology or the causes of PSC that we can target. And maybe, depending on what stage of the disease you're at, we should target a different area. This is a zoomed-in micrograph of what you see on a liver biopsy of a patient with PSC. And this is the bile duct at cross-section. That's actually an artery. And can you see the onion ring type or kind of pattern around that bile duct? So that's actually collagen fibres, fibrous scar tissue, forming a scar around that bile duct that leads to that narrowing. And so we know from the biopsy, we can see that there's an increase in scar tissue that's causing this. So I mentioned about targeting these these scarring mechanisms. One is by targeting an enzyme called LOXL2, or lysyl oxidase like 2. And this enzyme is something that lays down collagen, so it lays down scar tissue. And if we block it, then potentially you can block the formation and laying down of scar tissue. And Gilead have a drug called simtuzumab, for which we recruited patients recently in a phase 2 study. The results of this have not yet been released, although they've released some side results, but not whether it works or not. And it's being used in other liver diseases such as non-alcoholic fatty liver disease. You may have heard of obeticholic acid as well, which is it's a synthetic bile acid, and it's being trialled in primary biliary cholangitis, another bile duct disease, and it's beneficial in that. And it has many different actions, but one of its action is working on a receptor that's in the liver and in the intestine, the FXR, and when you target this receptor, it potentially has anti-scarring mechanisms. So by targeting that with obeticholic acid, you may reduce scarring. And they were going to be performing this study here in Europe, but Intercept, the company, have decided to just perform it in the USA, and so that's currently recruiting in the US. There's also a derivative of vitamin A called all-trans retinoic acid, which is also currently in a clinical trial in the US and supposed to have anti-scarring properties. So another mechanism is by altering the bile acid somehow, trying to flush out the toxic biles, which potentially is a mechanism of ursodeoxycholic acid. And this is a picture showing the makeup of bile. So you can see most of bile in red is made up of bile acids. They're interchangeably called bile salts and bile acids. And these bile acids enter into your small bowel to help break down fats and various things, so they help break things down. Bile also contains fats and cholesterol, and in the proteins it gets rid of lots of breakdown products of drugs and things like that. And in terms of the bile acids, it's made up of different types of bile acids, and I'm not going to go into each of them, save to say that some of them are good for you and some of them are slightly toxic. So you can change that composition of the bile acids by adding in a different bile acid, such as nor-ursodeoxycholic acid, which has one difference from ursodeoxycholic acid, and that's got one less particular side chain, but that completely changes its function and its effect on the bile. And it's been found to promote bile flow, so it helps the bile flow through and flushes through better. And when they've given mice who have a disease similar to PSC this treatment, they've shown the scarring around the bile ducts disappear and go away. And so it's now being trialled in PSC, and they've completed a phase 2 study, the results of which have been released preliminarily a month ago to show that it does reduce the ALP, and they're now designing a phase 3 trial, which we may be involved with here at Oxford. I won't tell you what ASBT stands for, except to say that it's a receptor that controls how much of the bile acids are reabsorbed in the small bowel to go back to the liver. And these are being used in reducing itch in certain liver conditions, and they're being looked at being used in PSC to potentially change the bile acid composition and benefit PSC. So the next way of targeting PSC and the cause of PSC is by manipulating the immune cells which particularly go to the gut, feeling that the immune cells go to the gut and in some cases go to the liver and cause the inflammatory immune-mediated liver disease of PSC. Now again, I don't expect you to understand everything in this diagram, but if you can imagine this is a blood vessel and the cells are floating along or shimming along in the blood vessel, but something stops immune cells to slow down and roll along the lining of the blood vessel and squeeze through into the gut. Now we need this to happen anyway. You need to have immune cells in your gut to get rid of bad toxins and bacteria anyway, but there are more immune cells in inflammatory bowel disease. And all of these little things that are on the edges of the white blood cell, as well as the little molecules that are on the edges of the blood vessel wall, are the things that cause that white blood cell to slow down, roll along and go into the gut. Things like CCR9, alpha-4 beta-7, MADCAM1. And these receptors and molecules have been targeted in inflammatory bowel disease with effect. And so by blocking these and blocking the cells getting into the gut, they have helped with inflammatory bowel disease, and I'll mention some of these in a moment, but potentially it could help in PSC because of the relationship with IBD. So one adhesion molecule that's on the blood vessel wall is called VAP1, vascular adhesion protein, and there's a drug that's been developed in collaboration with Birmingham University to block this molecule, and it's currently undergoing a trial in Birmingham, and it will start up here soon in Oxford, and it's also underway in Nottingham, and that's a phase 2 trial. There's also a drug that's already licensed for ulcerative colitis and Crohn's disease called vedolizumab, which blocks this integrin, it's called, a type of molecule on the white blood cell called alpha-4 beta-7, and it's very effective in vedolizumab, in ulcerative colitis, and has some effect in Crohn's, and potentially it could have a role in PSC. And this trial as well we are involved with in Oxford and will be recruiting soon. There are also agents that target other molecules involved in this pathway, such as MADCAM1 and CCR9, which are not currently in any trials in IBD or PSC, but potentially could be at some stage given the increased interest in PSC. And then the other way to target the pathophysiology of PSC is by targeting the bacteria in the gut, the so-called gut microbiome. And so one way, and one very old-fashioned way, is with antibiotics, by changing the composition in the gut. And there are small studies, again, really not more than 30 to 50 patients, and really to have a good effect and to show an effect you need to be in the hundreds of patients. And these were particularly with drugs like metronidazole and vancomycin, drugs which can have a lot of side effects. It's more common to have side effects from them compared with quite a lot of other more generic antibiotics. And also, if we started using them more widespread without a good benefit, we can promote resistance, which is a big problem if you're prone to infections in your bile ducts with PSC. So really, without much conclusive benefit with these drugs at the moment, we can't advocate them without a trial showing a definite benefit when there are so many possible side effects. But there is a trial of vancomycin underway in PSC in the US. I wrote fecal microbiota transplantation here. When Dr. Chapman and I wrote an article at the end of last year on new therapies in PSC, I thought I found that there was a trial in development, but I couldn't find it on the internet today when I was looking. But it is being looked at in trials in inflammatory bowel disease, and potentially it could be looked at in PSC, but I think they're a long way from that at the moment. So if you're interested in looking up what kind of trials there are going on in PSC, this is how you do it. If you want to perform a clinical trial in PSC where you are giving someone an intervention, you have to register it with clinicaltrials.gov. So you go to that website and you type in primary sclerosing cholangitis, and you come up with, today I came up with 64 hits. And you can click on each of them and there's a short summary and it will tell you where they're recruiting and how many numbers. This is the International PSC Study Group. It's probably even slightly larger than this. This is our 2-yearly meeting that we had a year and a bit ago. We've got one coming up in June. And together, because PSC is so rare, we try and join all our forces and work out what the best things are needed to research, and then do studies together where we each contribute patients from our own centres. So there's Dr. Chapman, and there's myself, and the person who you might not be able to see is Dr. Collier, who's hiding behind at the back. So I'm just going to gloss over some of the studies that the international group does. They have a very large effort on looking at predictors of prognosis, such as ALP, such as whether or not you have inflammatory bowel disease, such as age, your gender, and that is to be published soon, and still it's ongoing with going even deeper into prognostic markers. The use of FibroScan in PSC has not been properly validated, so a type of ultrasound scan which measures the stiffness of your liver. It's validated in hepatitis C and to an extent in hepatitis B and PBC, but not in PSC, so that trial is underway through this consortium. They're also looking at the use of anti-TNF treatments such as infliximab and Humira in patients with IBD who have PSC. It's not known how patients with PSC with IBD do with this treatment, so this is also a study they're looking at, as well as really going and giving representation at licensing bodies for surrogate endpoints in PSC trials. There's a big move there's a lot of stuff published from this group in the genetics of PSCs, and there are 16 genes identified that show you to be susceptible to PSC, not that you have to have them to get PSC, and there are other factors, as well as some immune genes, which has been found from this consortium. And they're also looking at novel ways of detecting cholangiocarcinoma, such as getting a urine sample rather than having to go and have invasive tests. And I haven't mentioned all of the studies this group is doing. I know there are some transplant patients here today, and they're also looking at the use of immune suppression after liver transplant because of the fact that people who have a transplant for PSC are at risk of developing the disease again. So they're looking at the best type of treatment post-transplant. And many of you will be a member of the UK-PSC Consortium as well. So this is where you sign up and you give a sample of saliva or potentially blood to learn about the genes of PSC. And if you're not, I urge you to get in contact with me or with your relevant doctor as to whether you can join this, because we're trying to invite all patients who are diagnosed in the UK. And this was set up by many of the experts, including Dr. Chapman, was one of the founders of this initiative. So very briefly, my research with my PhD, and I will be brief because it is quite scientific and basic science lab related. This is a very long-winded title. Safe to say that I'm looking at those immune cells, those lymphocytes that I showed you the diagram of in PSC and in inflammatory bowel disease. And there's that diagram I showed you before. This is data from Birmingham from over 10 years ago. And they isolated these immune cells out of the livers of patients with PSC, as well as out of patients with other liver diseases and healthy patients. And if you look at the proportion that express this gut homing marker, CCR9, 20% of the immune cells in the PSC liver express this marker, compared with 0 to 1% in all of these other liver conditions. This is just in the bowel, and you should have it in the bowel, so just ignore that bottom one. So you can see these cells with the gut homing marker on them are there in the liver of patients with PSC and not in any of these other livers or in the blood. And they shouldn't be there. They shouldn't be going to the liver. That's not where they're directed to. So the theory is that these gut homing cells could be playing an injurious role in the liver disease of PSC. And if you block these cells, that's why there's so many studies looking at this. If you block these cells, potentially you could be helping PSC. Now, this hasn't really been validated or shown since then, and so that's something that I'm trying to do, and I'm trying to tease it out more. What do I need? I need samples from patients with PSC, preferably with inflammatory bowel disease, but I am also looking at patients without IBD. I'm also having patients without PSC who have IBD to compare it with, and my theory is that the immune cells in patients with PSC and IBD act differently compared with if you just have IBD, and that's why you get the PSC. And I'm also getting samples from healthy controls. The type of samples I'm looking for are blood samples, biopsies at colonoscopy, liver biopsy, and I'll talk a bit about the fine needle liver aspirate in a moment. And then once I get those samples, I take them to the lab and don my lab jacket and my glasses, and I do a number of techniques in the lab to get those immune cells out of those tissue and samples. Just to say that any research I'm doing, the ethics has gone through the due process to make sure that it is ethically valid and reasonable. So when could someone donate samples? It could be at a clinic appointment, it could be at their endoscopy procedure, it could be if they're going for a liver biopsy. And I'm looking at potentially submitting ethics to perform a slightly lesser version of a liver biopsy using a much finer needle, finer really than they often use for blood as well, to take, instead of a piece of liver tissue, to suck out some of the cells. So it has been done in quite a lot of centres and has a very low complication rate. There is a sting just as the needle goes in, but it is much less painful and much, much safer than a normal liver biopsy. And this is something that I am interested in if people want to comment whether they would consider having this type of procedure for me to obtain cells, given that the risk is nowhere near that of liver biopsy. So I've just put those dates up there again, just in case people want them now they've heard why I want colonoscopy samples. Again, you would be invited for it as part of your clinical care, and so it wouldn't be performed if you didn't need it clinically, but then you might be invited to give samples as well for research. And just briefly, how can my research benefit patients with PSC? I guess we can, apart from understanding more about the cause of PSC, I think it's important that we understand the link between the gut and the liver and therefore identify targets for treatment. And so that's how I hope this research will benefit patients with PSC. So in conclusion, there is extensive research in PSC, both internationally and locally, new therapies coming on the market, working out how to predict risk and understanding the disease process. And I think that's really important, that we're doing more to understand the disease process rather than just blindly giving whatever drugs next on the list. I think we should be giving drugs that we can understand why they're working, if they're working, how are they working. And that's where, and I didn't mention that also in my research, I'm looking at patients' immune cells before and after they have some of these drugs like vedolizumab, so that if it's working, how is it working? And potentially we could predict who should get which drug, because I might be able to go back and say, well, that alpha-4 beta-7 was elevated in that patient, that's why the vedolizumab worked. So potentially it could personalise and stratify medicine. But we can't do research without the involvement of patients with PSC, and we're extremely grateful because everyone's been so kind and generous with their time and their samples. But I think the future looks good for patients with PSC in the current field of research. So thank you very much, and I just want to acknowledge all the people who've helped me with my research, and especially patients who've given me samples. Thanks.